Welcome to Dr. Balaga's God Knowledge Doc podcast, your quick dive into the latest medical breakthroughs to keep you ahead of the curve. Let's get started. Today is December 7, 2025. This video is on a special communication in JAMA Oncology titled Immune Checkpoint Inhibitor Associated Cardiovascular Toxic Effects, an International Cardio-Oncology Society position statement. What is the incidence of immune checkpoint inhibitor myocarditis? Approximately 0.75% with single agent therapy and 1 to 2% with combination therapy. Which cardiovascular events are most common? Cardiac arrhythmias, heart failure, pericarditis, acute coronary syndrome, and stroke occur more frequently than myocarditis. Who is the highest risk? Older adults, those with thymic tumors, autoimmune disease, and dual immune checkpoint inhibitor therapy recipients. What symptoms signal myocarditis? Chest pain, shortness of breath, palpitations, fatigue, even with preserved ejection fraction. What is the key differential diagnosis? Acute coronary syndromes which can coexist with myocarditis and must be rapidly excluded. How is immune checkpoint inhibitor myocarditis diagnosed? Using the International Cardio-Oncology Society criteria with troponin elevation plus CMR or magnetic resonance imaging or greater than 2 minor criteria. What is smoldering myocarditis? It's asymptomatic myocarditis with minimal abnormalities requiring close follow-up. Does troponin alone mandate stopping immune checkpoint inhibitor therapy? No. Troponin elevation of uncertain significance often allows continuation with monitoring. Which imaging modality is preferred? Cardiac magnetic resonance imaging for myocarditis confirmation when feasible. Should high-risk patients get baseline testing? Yes, including EKG, cardiac troponins, BNP, plus or minus echocardiography per European Society guidelines. First-line therapy for nonsevere myocarditis, IV methylprednisone, 500 to 1000 milligrams per day, then oral prednisone taper. When is the second immunosuppressant used? If steroid refractory with rising troponin or worsening clinical status. Which agent is preferred second line? Abatacept, sometimes combined with ruxolitinib. Which drug should be avoided? Infliximab due to increased cardiovascular mortality, especially in heart failure. How long should steroids be tapered? Approximately 10 milligrams per week, slower after reaching 10 milligrams daily. How is severe myocarditis managed? ICU care, high-dose steroids, pacing, cardiac defibrillation, and mechanical support if needed. What is the triple M syndrome? Myositis, myocarditis, and myasthenia gravis. This is associated with high mortality. How is immune checkpoint inhibitor pericarditis treated? Steroids with or without colchicine. NSAIDs for uncomplicated cases. Can immune checkpoint inhibitor therapy continue with pericarditis? Yes, if uncomplicated and monitor closely. How should acute coronary syndrome be handled? Standard acute coronary syndrome protocols with multidisciplinary coordination. What predicts worse outcomes? Peak troponin, conduction disease, abnormal LV strain, and elevated native T1. What is the 1-year mortality for severe myocarditis? Approximately 28% versus 5% in non-severe cases. How often does myocarditis recur and rechallenge? Up to 38% in limited data sets. When is rechallenge appropriate? After recovery, minimal immunosuppression, and strong oncologic indication. How should rechallenge be monitored? Serial troponin reach cycle and periodic imaging. If you enjoyed this episode, share it with your colleagues When we change how we see disease, we change how we shape lives. Until next time, stay curious, stay compassionate, and keep seeking wisdom. Podcast brought to you by masterbedfacts.com. This podcast is for physicians and healthcare providers. If you enjoyed this video, please like, subscribe, and forward to your friends.